Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Tercera Therapeutics. My name is Rain Bennett. I will be your host. I'm a filmmaker. I've been working with CCF for almost a decade. I believe it was 2011, maybe, when we started working together. And part of my job, a big part of my job, and what I do with CCF is we create video projects like this live series, like produced videos about treatment, patient journeys, all kinds of things to all raise awareness and educate people about this disease. That's our mission, and we've found it to be really effective to use video to do that. So this is been a project, an ongoing project, not just Luncheon with the Experts, but all the video work that I do with CCF for, like I said, a decade, and it's a community that I am very proud to be a part of. So speaking of this community, if you are a part of the community that joins us every week, you know the drill. Let us know where you are in the world. Say hello. Tell us where you're signing on from. Every week, I am so shocked and surprised by the reach that we have and the regulars that we have in Kenya and Australia and South Africa, all over Europe, places where people should be asleep, but they're not. They're spending this time with us, and that's awesome. That's amazing. So let us know where you are in the world. And of course, before we get started, we want to thank our sponsor, Tercera Therapeutics, for their support of the series. We couldn't do this without them. And a quick disclaimer from them. We want to say that the opinions expressed by our guest presenters, as well as the questions asked by the audience, have not been created or suggested by the sponsors of the Facebook Live program ahead of time or at all. CCF does not endorse or promote any of the views, opinions, or information provided in the presentation. And audience members, that's you all at home, should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health and treatments. So, as I always say, that last statement is really the takeaway there, which is we're going to give you some advice, hopefully some guidance, but by all means, we don't know your case and we won't be able to go specifically into it. So any decisions about your treatment you need to make and discuss with your home treatment team. So today's guest is Dr. Alexandria Phan. How are you, Dr. Phan?
I'm good. I'm very happy to be here.
Yeah, we're happy to have you. Tell everybody where you are signing on from. Where are you based?
So I'm currently in Tyler, Texas. I work for the University of Texas in Tyler, Texas. I'm about 4 hours from Houston, Texas, and 2 hours from Dallas. It's a small town, but we still have a few patients that has neuroendocrine tumor here.
So what exactly do you do in this NET community? How do you serve NET patients?
So I have been doing this, or meaning taking care of neuroendocrine tumor patients for 20 years. I'm a medical oncologist, specifically a GI medical oncologist. I have worked at various places, including University of Texas at MD Anderson in Houston. And right now I'm a professor at University of Texas, Tyler. Essentially, I'm a Texan girl, so.
You're a Texan girl. Yeah, I heard that. Yeah, and Texans are always quite proud of that. You know what? I'm a North Carolina boy, and we're proud of that too. But man, there's something about Texas pride that's a little bit different. Okay, everybody. So Luncheon with the Experts, you know the drill. We've got an hour with Dr. Phan. She's been gracious enough to give us her time, and I'm sure you have questions, so get them in. And just know that if we don't get to your questions with respect to all of our times, that you can always send a message to CCF either here on their Facebook page. You can private message them, or you can reach out to them at their website, carcinoid.org. And any follow-up questions you have or further direction you need, they will be able to provide you. Something I like to let people know when we're asking questions is if you see a question in the comment thread that you also have or that you like or that you would like the answer to, go ahead and star it or like it or love it, or, you know, if I see that multiple people have liked a certain question, it kind of upvotes it. It lets me know that, okay, this is in demand. We get a lot of questions. We never get to all of them. So it lets me know, hey, a lot of people have this question. I'll make sure that we get it across and hopefully get some answers to you. So send those in. And before we get started, one more announcement I wanted to know. Have you downloaded CCF's free Net Cancer Health Storylines app? The app makes it easy to record your symptoms, medications, nutritional concerns, moods, and more. So go check it out. And if you have checked it out, let the people know in the comments what you like about it and how it helps you. And if you haven't, go check it out now. So let's say hey to everybody. I'm starting to see where people are coming in from. So Puerto Rico already. Tom, hi from the Pacific Northwest with coffee with the experts. Indeed, this is the old talk show trick. It's actually water, seltzer water in here, but that's my luncheon with the experts mug there. So Dr. Phan, let's go back a little bit. Let's hear a little bit about your early journey and kind of what led you to this disease. Did you know you wanted to go into oncology? What was the path that brought you here?
So I think most people who does oncology are affected by cancer. My story is that both my parents died of cancer 9 months apart in their 40s.
Wow.
So, and it's a young age to be dying or affected by cancer. So I had two choices. I always want to be a doctor. I have two choices. So I can go to do something completely separate from cancer, like ophthalmology, where my sister did, or doing cancer, taking care of patient, because I think that actually helps me feel like I'm helping my parents. So that was the reason I went to cancer or oncology.
All right. Yeah, we're going to have some fun today. I don't know if how well you know me, but the folks watching do. I'm a storytelling person, big on sharing of stories, and we do that within the community here. And I hear that. I love that. I have a similar path. I'm not a doctor, but I am kind of have landed in this health and wellness filmmaker role where the projects that I'm passionate about are those. And I also lost my father. I'm grateful enough and fortunate enough to still have my mom, but I lost my father to cancer and other family members. And I come from a part of the country that is, riddled with it and other kind of heart disease, diabetes, et cetera. And so it took some work later, some self-work later in life to realize like, oh, there's a reason why I'm attracted to these projects that help people with their health. And so out of the gate, I resonate with that and relate to that so much. And I love when people are purpose driven like that and have some underlying mission behind it. And I'm sorry to hear that about your parents. That is a tragically young age. But I do love how it launched you into this way of trying to help people in that similar situation. I think that's very important. What about into the specific realm of neuroendocrine tumors? Because now, you know exactly where to go.
Yeah. So this is what I tell my patient. I actually tell my patient is that I don't see a patient as a patient. I think each of their journey is very different. And having experienced that with my parents, I can be on the other side and know what they're anticipating. And I think the most important thing is that they have to feel comfortable they have a partner in this journey, however long it is. And neuroendocrine tumor is an indolent disease, so I'm very blessed to be able to be a part of patient life for a long time, meaning decades sometime. But how I got into this is this. Once I get into oncology, I also pick disease that is sort of an orphan disease or cancer that most people don't have treatment. So when I start taking care of patients with neuroendocrine tumor, there was not even a treatment that's approved yet except for a somatostatin analog, octreotide or lanreotide or whatever. That was the only thing we have. And so I picked that disease because of its rarity and uniqueness. I'm a curious mind. Every single time somebody comes in with a diagnosis, it's fascinating to me on how long it takes for a correct diagnosis to be made on this cancer. So the motivation for me is things that are difficult for other people. The motivation for me are things that people shy away from. I pick those because I think that's needed. So that's how I got into this. Yeah.
So you like a challenge.
Yes. Yes.
So you mentioned, and I'm sure many people watching today are familiar with the unfortunate length of time of for diagnosis often with this disease. What are some of the other challenges, as you said, everybody's journey with this is different. Everybody has their own unique story. What are some of the common challenges in this rare disease that you've seen over your time working with it?
So yes, it's actually that's a very good point. So neuroendocrine tumor is an indolent disease. It's slow growing disease, but nevertheless, it takes life. It does shorten life, but it actually presents with very vague symptoms that most people will blame on other things. For example, the common symptoms of diarrhea, flushing, wheezing, all of those things can be blamed for other things, more common things, asthma, rash, acne, menopausal hot flashes, diarrhea, IBS, inflammatory bowel disease. Any of those things will be blamed first before they're correctly diagnosed. So I think the challenges to your question is, one, that it takes so long to correct the diagnosis, to make a correct diagnosis. So patient goes through this course of their life thinking they're going crazy because nobody believed them that they have symptoms. Something is wrong. So then it's the frustration, it's the buildup of a lot of medical costs and a lot of frustration of not knowing what their diagnosis. One, that's the first challenge. The second challenge is mainly because not a lot of people are aware. A lot of patients, before all of these new therapy become developed, which is just recently in the last maybe 10, 15 years, 10, 12 years, they have been told, don't worry about this. This is a slow growing cancer. Go home. Don't even bother about taking care of this cancer. That's the myth of this cancer that need to be demystified. And the third challenge, I think, is that because it's an indolent disease, it's difficult to find treatment. And because it's rare disease, not a lot of company are into this to find treatment for this cancer. So that on the surface, those are three most important challenges to me.
Well said, well put. And a lot of people are responding to that. I'm seeing a flood. You can't see this, but I see a flood of the thumbs up emojis coming. And so for those of you at home, when that happens, if Dr. Phan, helps you out, answers, that's a visual way that we can see that you're getting value out of this, which is absolutely our goal. And if you really get a lot of value, there's a little heart emoji you can send too. But yeah, that always helps. And so I wanted to ask a favor for everybody at home too. We're about 10 minutes in. Clearly we have a top mind in this space with this disease today. So this is a fortunate opportunity for all of us to learn. So if you know somebody that would benefit from this, you can go ahead and tag them in the comments or share this video to their page and let them know this is going on so that they can join us live and maybe get a question in that they have. And get an answer, hopefully, that they are seeking. However, if they don't, or if you want to revisit the video, just know that it will be evergreen. It will live here on the Facebook page under the videos tab. And starting Monday, we actually republish it to YouTube for anyone that that doesn't have Facebook, so they can watch it there as well. But we still have plenty of time today, so go ahead and share this video. Let people know that it's going on. And Dr. Phan, as I imagine, we have questions pouring in, so I'm going to go ahead and pivot to that. I know that you and I could talk just by hearing your journey and your story and your passion behind it. But I want to serve the people. Before we ask some questions, I have a comment from Gary, who says, "Hi, Dr. Phan. I was a patient of yours at MDA in Herman from the recovery in the hospital in March 2009. I'm still hanging on." So he's sending some love, and we're sending love back to you, Gary. I had a question from Sherry. Now from Sherry, do you see patients with lung nets and dip neck, first of all?
Yes. So, okay. So Sherry, I do. I see all spectrum of neuroendocrine tumor. So yes, neuroendocrine tumor of the lung is something that used to be seen by thoracic medical oncologists, but more and more people in neuroendocrine tumor, more and more doctors specialize in it, are seeing them. So I do see them.
So, and a more specific question from Sherry is, if so, how do you treat dip neck cough? And let's establish what dip neck is for those that aren't familiar.
Dip neck is a chronic condition that actually has essentially pulmonary endobronchial neuroendocrine hyperplasia, multiple tumors in the lung. And yes, there are coughing that is associated with it, and oftentimes it's a challenge for pulmonologists to take care of it. There is no right, wrong answer on treating this, because there's no guideline on treating this, because it's not considered by many people to be a malignant condition. It's considered a benign precancerous or some benign condition. So the treatment is oftentimes just supportive measure. I personally sometimes, if nothing improve, I sometimes use somatostatin analog. In some patients, that helps their cough or their breathing problems associated with DIPNET.
Got it. Thank you, Sherry. Thank you, Dr. Phan. And by the way, I know we mentioned at the top of the program that we have a videos that we do produce videos as well. We're currently working on a series of 9 longer form, not as long as Luncheon with the Experts, but longer form videos based on different issues with treatment of NETs. And so we specifically have one coming out about lung NETs and DIPNET that I'm working on now, should be out in the next month. And we have one coming out next week, I believe, on clinical trials. But these are also on the videos tab, also on the YouTube channel. We've covered a lot of ground this year: PRRT, NET guidelines, multidisciplinary teams, a lot of rich content there. But since we just talked about lung NETs, it made me think about that. Okay, moving on from Gina. Maybe Jenna. Is there a correlation between B12, folate, and serotonin levels?
I don't know. I don't know of any data on that. B12 and folate is actually an important ingredient or nutrients to a lot of the patient that has carcinoid syndrome, because when you have carcinoid syndrome, especially if you have diarrhea, you'll be losing a lot of those nutrients. And if you have guts that has been, your bowel has been resected for the primary tumor, you cannot absorb some of those things because of the location of your bowel that has been removed. So a lot of patients are short or not able to absorb that. So B12 and folate is very important to continue taking. I don't know that there is any relationship between that and serotonin in the mechanism or the metabolism pathway. So for me, the answer is I'm pretty sure there's none, but it's common to be deficient in B12 and folate because of the carcinoid syndrome and diarrhea that makes people lack these nutrients that normal people can absorb.
Sure. Got it. Thank you. Next question from Pam. This is about PRRT, which I know a lot of people are interested in and helps a lot of people. But Pam says, what would be the next treatment after PRRT? My husband had 4 treatments 2.5 years ago. So it looks like she's looking for something else after that. Any thoughts or advice for Pam?
So Pam, it's something that you probably would spend time talking to your oncologist or your physician. PRRT is one aspect, or peptide radiolabeled radiation therapy is one aspect of treatment modality. There are other treatment modality beyond PRRT that you may or may not have tried. There are systemic targeted therapy, there are systemic oral chemotherapy, and then of course there are PRRT. There are also ongoing clinical trial with other radiopharmaceutical agents in the arena of neuroendocrine tumor or carcinoid tumor that you can enroll in as well. The issue is how much dosage of radiation have you gotten, and can you get more of that? That's the important one. And that can only be done by essentially another discussion or another assessment of dosimetry. How much of radiation have you gotten, and how far away from the last treatment have you gotten? But there are a lot more treatment nowadays than it has in the past. So I don't think that just because you finish PRRT and have essentially did not benefit from it, that is it. There are other options, but you have to explore that with a provider that is specialized in neuroendocrine tumor.
Got it. Thank you. Another next step question. As we know, this is a journey for people. From Myra, who says, what is the next step if a tumor near the portal vein causing compression cannot be surgically removed?
Okay, so Yeah.
Too
So
specific or?
yeah, that's a little specific. Is it's if this is metastatic disease, meaning the cancer has spread outside of where it started, and it involved the liver and it has portal vein thrombosis, then your question is related to whether surgery is possible when you have portal vein thrombosis. The question is more specific to whether you can have surgery when it's metastatic disease. So I wouldn't need to have clarification if it's portal vein thrombosis and have no other sites of disease, or portal vein thrombosis because you have multiple sites of disease in the liver or elsewhere, because the management probably is different.
Got it. Myra, if you do want to send some more context, some more information, please do that. Let's talk a little bit about surgery. From what I know, most people, that is kind of the first line of defense. But when does it stop being a tool that you can use to treat this disease?
That's a very good question, actually. Surgery is something that I always think about because, number one, if you can make the patient surgically no evidence of disease, you can actually prolong their disease-free interval or their life expectancy in some study that has demonstrated that. So I'm a very much a believer in multidisciplinary care, in the sense that you have to discuss the patient case at every point in their journey with a team: your surgeon, your interventional radiologist, your nuclear medicine doctor, and your medical oncologist. So surgery is always an option, but you have to know your goal. What is the goal? If you have bulky, multifocal disease, removing the surgery is not going to extend your disease-free interval, because it cannot, because there's multiple focus. But if your goal is to palliate the symptoms of pain, for example, let's say a bulky disease can cause pain, and the patient's risk and benefit of going to surgery and surviving through surgery and recover well to get that benefit is present, then it may be an option. So to go back to your question, surgery is never an end all of everything, and it's never never done when you have metastatic disease. Or when you have metastatic disease, that doesn't mean that you cannot have surgery.
Right.
And when you have surgery, that doesn't mean that you don't need anything else. It's a whole spectrum of the natural history of neuroendocrine tumor.
Awesome. Great, thorough answer. I appreciate you for that. Moving on with questions from the audience. From Nancy: do you recommend a gallium dotatate PET scan first, or a CT and Octrio scan first?
That's actually a brilliant question, and I think I may irk some people if I say this, but I stopped using octreotide scan. It's, to me, is not essentially sensitive enough to pick up disease, and it's too fuzzy to specify the location of disease as well. So for me, I have replaced octreotide scan with PET gallium dotatate. The problem with that is, of course, insurance approval. Insurance will not approve PET gallium for restaging multiple times. They do approve it for initial staging, and sometimes additional restaging if you get peer-to-peer and get it approved. So the answer is PET dotatate or PET gallium is preferred over octreotide scan. PET dotatate and PET gallium does not replace CT or MRI, because, again, in order to see, let's say, the liver or the bulk of disease in the liver, an MRI of the liver is more preferable than a PET gallium. PET gallium serves two purposes. One is to look for extent of disease, and the other one is to look for receptor status to determine if you're a PRRT candidate. So those are the reasons I would use PET gallium. And again, I don't use octreotide scan much nowadays.
Got it. Thank you, Nancy and Dr. Phan. I will never mind if an answer you have will irk some people. So we we don't mind getting controversial. We're trying to make progress here. By the way, that answer, you mentioned insurance, and that's an issue that comes up for a lot of people. So for those at home We did have Laurie Todd, the insurance warrior, on a couple of weeks ago. So that's a really good episode that addresses, how to appeal some of your claims that have been denied. So just thinking about that, because insurance is a topic that comes up a lot, that people struggle with this disease and certain coverage. So that episode may help you if you want to revisit that one. Question from Amber: what is your opinion on treatment for a NET in the appendix? On treatment for appendix neuroendocrine tumors.
Amber, that's thank you so much for your question, Amber. Appendiceal neuroendocrine tumor used to be thought it's the most common one. The natural history in some cases is considered appendiceal neuroendocrine tumor to be benign versus malignant. But I don't think that's easy to classify that way, because I have had several appendiceal neuroendocrine tumor that does come back and metastasize. The answer is I would treat them like a neuroendocrine tumor of the midgut. I think to your question, this is actually relevant. Neuroendocrine tumor of the appendix that occur in children are typically benign. So if you're under 18 or under 20, at MD Anderson, when I was at MD Anderson, we did a literature, not a retrospective study of all of the patient that pediatric that has appendiceal neuroendocrine tumor. Majority of them are essentially cured after surgery and they don't have metastasis. Majority meaning more than 80%. So the answer is that depending on the age, appendiceal neuroendocrine tumor can be benign versus malignant, but malignant neuroendocrine tumor of the appendix does occur. So I would treat them based on guideline the same way, and don't say that they're benign, I'm not going to treat any differently, I don't monitor differently, I follow guideline in monitoring them. So hopefully that answers your question, Amber.
Great. Yeah. Thank you. And thank you, Amber, as well. Switching back to lung nets, you got a question from Joe that says, after surgery and radiation for a lung net, is there any treatment available if no receptors are present?
Yeah, so that is, Joe, that is actually an ongoing topic in the community of neuroendocrine tumor, as well as in thoracic medical oncology. Lung neuroendocrine tumors, the classification of lung neuroendocrine tumor are still stuck between lung typical carcinoid, lung atypical carcinoid. The neuroendocrine tumor of the lung also is not very well defined. So if you don't have a classification that's well defined and well accepted, it becomes very hard to develop guidelines on that. But to your specific question, if you don't have receptor positive and let's just say you have metastatic neuroendocrine tumor of the lung, then the question of systemic therapy will depend on the Ki-67. That's the proliferative index of the tumor, whether it's a fast-growing tumor or an indolent tumor, whether it's a typical carcinoid tumor of the lung or an atypical carcinoid tumor of the lung. So the way I treat these patients is, number one, I check out the Ki-67. I check out also Foundation 1 or some molecular profile or fingerprinting of their tumor to look for targets, because now you know now that there are a lot of specific drug that is designed for specific target. So knowing that is also helpful. And getting involved in clinical trial will clarify a lot of the option moving forward in the future for lung neuroendocrine tumor. So the answer is there are options. You need to explore that again with somebody who knows about neuroendocrine tumor of the lung.
Lovely. Thank you. Okay. Lots of comments coming in now, lots of questions. So we're gonna keep moving forward. We're almost halfway done, folks. If you're just tuning in or tuned in late, this is Luncheon with the Experts, and today our guest is Dr. Alexandria Phan. We are already diving deep, so if you have time, go ahead and get your questions in. This question from Jody is interesting. It says, is it occurrence of NET or diagnosis of NET that is rare? What simple screening could you recommend for physicians treating family members with similar symptoms to a NET diagnosed patient? You follow?
Yes. So there are three questions to that question. So
Yes.
thank you so much for asking that question, because it allowed me to pontificate. So one and most important thing, I think the first part is screening. There is no screening for neuroendocrine tumors. Essentially, that's known at the moment. As you know, screening or recommended screening is based on how many you have to screen to get to affect or to make an impact. And because neuroendocrine tumor is so rare, it's unlikely to have a screening guideline. So I would say that for colorectal cancer screening, colonoscopy, mammogram, all of those things have guideline because they have an impact because they occur at a higher frequency or higher incident. Whereas neuroendocrine tumor doesn't have that, so there's no screening. However, the next part of your question is that you need to know if you're at risk. If you have family member that has neuroendocrine tumor, especially at a young age, you need to decide. You have to work with a genetic counselor or with their history to see if they have a specific gene related to their cancer or not. There are essentially 4 hereditary conditions relating to neuroendocrine tumor, especially pink neuroendocrine tumor. They are MEN1, which is multiple endocrine neoplasia. That's number 1 gene. Von Hippel-Lindau, neurofibromatosis type 2. And then the other one is tuberous sclerosis type 2 as well. So those are the genes that actually increase your hereditary condition risk to getting neuroendocrine tumor. So if they exist in your family, then you are at higher risk. Then you need to be involved in a program to be screened, to be monitored for those conditions. And one of them could be a neuroendocrine tumor carcinoma. So going back to your first portion of your question is about, is it the diagnosis that is rare or is it the incident that is rare? The diagnoses are delayed. The correct diagnosis of neuroendocrine tumor are delayed. But the incident of neuroendocrine tumor, that is the number of patients that is being diagnosed per year, are also very rare compared to other cancer. But that incident is increasing. So the prevalence is the number of patients that has neuroendocrine tumor in any period of time is increasing. We're diagnosing more of this rare cancer and more patients are living alive, so the prevalence is increased. That's why, despite the fact that we keep saying this is a rare disease, but you turn around, you say, oh, that person has neuroendocrine tumor, that person, it's because they live longer with it. So the prevalence is increased. The incidence is also increased because they live longer once they are diagnosed than most other cancer. But it's still nevertheless a rare disease because the frequency of the diagnosis is actually less than any other cancer that's being diagnosed. I hope that explained the statistic.
Yeah. It is clear Dr. Phan is a pro. My goodness, she can handle any set of questions you send her, folks. From Allie, as a general rule, do you recommend monitoring liver lesions / metastases over pursuing interventional radiology solutions to treat them?
I almost want to ask Allie where her question is from. So yes, there are regional, I'm not sure exactly what you're asking, but
okay.
You do monitor disease. So neuroendocrine tumor metastasizes to the liver frequently. So we monitor disease in the liver frequently, not frequently, but at a time interval that makes sense to the natural history of disease. So we have to monitor it with specialized tests because you can't just do a one-phase CT scan and expect to see metastasis in the lung. You have to do multiphasic CT or MRI to see disease in the lung. Monitoring disease versus treatment, that is all depend on the clinical scenario, the risk and benefit, and the option. Many places, when you have an indolent disease, you don't have any symptoms, and you have 1 or 2 spots in the liver, some physicians choose to just monitor instead of treating. I take a different approach. If I can address the disease quickly so that they can actually have some measure of control of their disease earlier on rather than waiting until it exploded and then trying to treat that, I do things a little bit more proactively than other people. So the answer is it's different based on the provider. There's no right or wrong, because there are indication in the guideline that if it's an indolent disease, it's not growing anything and it's not causing symptoms, some provider will choose to just monitor instead of doing something. Other provider will try to do more. For example, if I see one or two, I like to have it removed in the liver so that then I don't have to worry about the disease causing more problem down the line, because you're young when you're finding those. If you wait until 10, 15 years later, you could be in your 70 and trying to talk about surgery. So my approach is a little different than maybe many of the community doctor, is that I like to be proactive.
Got it. Hopefully that helps, Allie. If you're still around, I want to give you an opportunity to, get the answer and the guidance you need. I do see that you had a lot more in your question, but so much so that I would have to like click the read more thing. So there's just a lot of about your specific case. So this is actually an opportunity for me to help you all at home, help me. So sometimes I think that people may feel that the more information they give about their disease, maybe the easier it is for us to answer, but it actually just, it makes it more challenging. And it, as we said at the top, we can't really get into your specific case. So you kind of have to be creative to get the answer that you're seeking, or at least the guidance that you're seeking, where, so that you can take that back and take it to your home team. So think creatively about how you can word just a simple question, but simple is a lot easier for us to field versus all this nuanced, minute details about your disease. It's honestly so much that sometimes it's hard to get to all that information because it goes past what I can see on the comment thread. So anyway, just a note that would be super helpful. Next question from Jeremy. In general, this is an interesting question to me. Do those with carcinoid who go to the dentist for procedures which call for epinephrine, such as tooth extractions, do they need a Sandostatin IV drip? Can you, so, I'm not really sure where we're going. I just know that I haven't had a question like that before. So how does that question strike you? Can you?
So that question applied to perioperative procedure for patients who have carcinoid syndrome.
Okay.
There are guidelines for perioperative management for patients that needs to have epinephrines or any kind of anesthesia for general anesthesia. There is some guideline for that. I think even ENED and NENET has them. For a dental procedure, I'm not sure that you need a drip, but I see it's kind of hard for me to gauge what epinephrine is given during a dental procedure. I think it is worthwhile to discuss a procedure that will involve epinephrine for a patient that has carcinoid syndrome between the oncologist and the dental surgeon. I think it is worthwhile to discuss that because, for example, if you have a carcinoid syndrome that is very much easy to have a flare or a crisis with one of those drugs, it is actually better for the oncologist to discuss and prepare the patient before a dental procedure, especially a dental procedure that can be invasive. Most dental procedures are mainly not so invasive. They don't need general anesthesia, but if epinephrine is involved, it is worthwhile to have that conversation between those two doctors.
Got it. All right. Thanks, Jeremy. Hopefully that helps. Next question from Caitlin, who lives in a place in Canada where gallium-68 is not available to them. Is octreotide the second best option?
It's the only option if you don't have PET gallium. Yes, it is adequate enough to determine if you have receptor status for PRRT. It is also adequate enough to see if you have occult metastasis or sites of disease. It's not as great. So if you think of an A, B, C, D as far as grade, like when you go to high school or college, I would say if I put PET gallium as an A, then I would say octreotide scan would be a B or B minus. So I think it's adequate. It's not A, but if you don't have PET gallium, it's served a purpose.
For sure. Absolutely. Hopefully that helps. Okay. Next question from Tracy. If a patient has symptoms of NETs, blood tests showing the presence of multiple NETs, repeated and confirmed twice, but the gallium-68 does not show tumors, what would you do next regarding testing or possible treatment?
Okay, let me get this clear.
Yep.
So if I presume the question is that they have multiple lesion on a PET scan, a regular PET scan? Is that what the
I'm not
question
sure. It
is?
says if a patient has symptoms of NETs, which Tracy doesn't clarify what symptoms, blood tests showing the presence of multiple NETs. And she says in parentheses, repeated and confirmed twice, but the gallium-68 does not show tumors.
Okay, so the question is about imaging that does not show tumor. And the blood tests show elevation of, let's just say, chromogranate A or something, and the patient has symptoms of diarrhea or flushing. Unfortunately, in oncology, the treatment of anything with toxic agent or potentially toxic agent or anti-cancer therapy require a tissue diagnosis of cancer. So if you can't find the cancer on imaging or a mass somewhere, you can't biopsy it. And so oftentimes it's hard to say you have this diagnosis. So at the current moment, the diagnosis of neuroendocrine tumor is made by a tissue diagnosis, okay? There are patients out there, and I have seen some of the patient out there that has occult disease, meaning they have very little disease that cannot be detected by imaging. Remember, imaging has a limit of detection as well. So just because you can't see it doesn't mean that it's not there. It's just not big enough to be seen by imaging. So they may have symptoms, but they don't have imaging detectable disease. So sometimes it is useful to actually discuss a therapeutic trial of somatostatin analog or something to see if their symptoms improve or not. And I wouldn't do that for a long period of time, but I would do it for a defined period and see if that helps them. And I also am a believer in having a second opinion whenever you have that, so that another a different viewpoint may look at something that somebody else has been looking at it for 2 or 3 years and can't find the primary site. So the answer is that broaden the differential diagnosis up and consider a trial of therapy to control the symptoms.
Got it. Okay. Thanks, Tracy, for your question. Hopefully that helps. And speaking of blood tests, I have a question from Karen, a friend of the show. Hey, Karen, good to see you again. And also, this question has been upvoted or liked 5 times. So that tells me that there's other people with this question. Thank you, everybody. That really helps. Follow directions. Also, Karen, I see your little clever use of the asterisk to maybe catch my eye. I don't know, but it worked. What blood tests would you recommend to find out what vitamins and minerals you are lacking? What was that phase?
Yeah, Karen, there's no one blood test that will have, it's not a panel blood test to look for vitamins or deficiency. I would go by clinical scenario. So if somebody has a bowel resection, large, multiple segment, a long segment of small bowel resection, I would do a certain test to look for B12, folate, vitamin D, all of those things that is important, that is absorbed in the small bowel. And if somebody has an upper gut resection, I will also check for folate, B12 as well. There's no specific vitamins that is that you can actually just say, okay, these patient needs to get this. It's based on what their symptoms is, or the nutrients, the manifestation of the nutrient deficiency that is lacking. And then you chase after that with blood tests. Sometimes it's not one, it's multiple. So it's not that clear cut, but I would say I let my clinical symptoms and manifestation guide me in deciding what blood tests and what nutrients panel do I need to get to see what they're missing essentially.
Got it.
I don't know
Thank
if
you.
that answered Karen's question, but
Hopefully,
that was my
Karen, and
attempt.
let us know if you have a follow-up question. And obviously, there is other demand for that information. So if Dr. Phan can give you a little more clarity, let us know how we can help. And I just want to pause for a moment and let everybody know we have about 15 minutes left. So if you do have those questions or need some more clarity or clarification on a question that you had, go ahead and get those in now. And for you, Dr. Phan, I just wanted to read a couple of comments because apparently you're doing a great job. People are saying, excellent description of frequency, incidence, and prevalence. Thank you so much for answering my question about the scans. Awesome information. Thanks for being a messenger of hope. That's probably my favorite. I love that. So people are really responding and appreciative, as am I. Let's scroll forward. We have a few more questions, lots of more questions. Okay, here's one. What is your opinion about Y90 therapy? And let's take a moment and describe what that is for metastatic live tumors.
Metastatic liver tumor.
Liver tumors. Yeah. Thank you. How did you know that? You're not even seeing the word, but I'm like, I just read. And so I can't, it's hard for me to put the context to it, but you hearing it, you're like, that's not right, sir.
I know because I've been through this. Just like I said, it's been doing this 20 years, so I can actually anticipate some of the patient questions
Yeah.
and their concern. So for metastatic disease that occur in the liver only, or without extrahepatic disease, there are the treatment can be done with what we call liver-directed therapy. And liver-directed therapy can be done by multiple ways. The liver can be accessed through multiple sites, your arms, your neck, your groin, and they're looking into the artery that feed into the liver. Artery feeds essentially tumors in the liver, whereas vein feed normal liver, which is why that separation allow for effective liver-directed therapy for liver metastasis or liver spread disease that spread to the liver. So there are many agents that is used to treat those diseases. So liver-directed therapy can be done with chemotherapy. So chemoembolization, or what they call transarterial chemoembolization. Liver-directed therapy can be done with radioactive material, Y90. That's a radioactive particles that is injected through the artery, delivered to a specific site in the liver to kill off the liver cells, okay? That's Y90, and I'll answer your question in a few minutes. And then there's other treatment that can be done. Bland embolization is another liver-directed therapy where they go in and they stop the blood flow into that artery that feeds that tumor so that the tumor can die off. That's bland embolization. It does not add chemotherapy. It does not add radiation. It's just bland embolization. So to answer your question about Y90, the reservation about giving Y90 in patient with had neuroendocrine tumor that is spread to the liver is the dosage of radiation to the liver if they're going to be getting more radiation with PRRT down the line. That would be, the thought is that it would be too much radiation in addition to adding both of them together. So in my practice at the moment, if I think the patient is going to have a chance for needing PRRT, I try to talk to the interventional radiologist about treatment with bland embolization without adding radiation. So then they can have that option, full force option of PRRT treatment down the line without having to add additional radiation to the liver. Now, the interventional radiologist would say our dose of radiation with Y90 is not that much, so they can get PRRT down the line too. That is true. But if at all possible, I do not like to burn bridges. If I think they have an option for PRRT, I try to utilize bland embolization instead of Y90. But if Y90 is the most effective and they won't need PRRT down the line, or unlikely to need like in the next year or two after that procedure, then I would consider that a reasonable option. Every single person is very different situation. To answer your question is, I pick and choose so that I don't lose the option of future therapy. That's important to me.
No, yeah, that's important. That's a great point. Another superlative for you, doctor. Best doctor yet. I'd be remiss if I didn't include that one. And listen, I won't tell the other 12 or 15 that we've had on the show already, but Mark says best doctor yet. So Erica says hello and thanks from Ottawa. Erica, funny story. I'll just take just a second to say it. That was the first place, I forget what conference it was. Grace, you probably remember, where I worked with CCF a long time ago, almost 10 years ago, and where I met so many of the people in this community, Dr. Wolin and Woltering and probably Dr. Lou and Josh Mailman and Leanne Burns. And that was my big introduction into the NET community. So Ottawa, which is the only time I've been there, always strikes memories of that. Okay, here's an interesting question. And speaking of other doctors on the show who, you know, you're the best doctor yet, according to Mark. Just want to throw that out there again. What we had in the first episode of Luncheon with the Experts, Dr. Irvin Modlin on, the creator of the NET test. So Linda's question is, what do you think of the NET test as a NET screening tool?
Yeah, so Dr. Modlin has been doing the NET test, and yes, I think it has validity. But for me, I need a little bit more information before I can use it as a mass test. I have been using it on a few selected patients who can afford to do it. I don't have a negative or positive. I am still assessing it, but some patient would benefit from the NET test. So I think it's useful in some cases, and it may not be useful for the whole group of people that has neuroendocrine tumor at this time yet.
Let me ask you a follow-up question, because many people ask about this, and many doctors or people answering the question are kind of where you are on it. Like, I see some good things, you know, maybe they don't know enough about it yet. Maybe they don't have enough experience with it yet, but they're still teetering, right? So my question is, what would you need to see to sell you on it, for lack of a better term, for you to have a lot more faith behind it? What's missing?
Prospective data to validate the NET test. Prospective large trial that actually has comparator to what we're doing right now to show a benefit. Essentially, a test that will be useful, whether it's useful on predictive or prognostic. How is that going to add to the data that we're using right now to predict or prognosticate patient that is already available? How is that going to add more? So I'll put a different perspective. In my community, rural place, patients do not have the savviness or the money or the access to a lot of these new innovative things. So can we get by with some of the things that we do? I mean, can we still optimally care for these patients with the standard that we're doing? The answer is yes. If NET test exists, can that be better than what we have? We need prospective large trial to answer that. But if you have the ability to access that, you're in a place that makes sense and your doctor would agree to do that, why not? You can use that. Yeah. But for me to recommend something broadly, I need data perspective. And at the end of the day, I'm a nerd. So that is very important to me.
Oh, yeah. That's awesome. I love that. Thank you for such a straightforward and honest question. And I totally get it. I mean, the people that I fight for and the work that I do, I come from a rural community as well. I think that's a really great point that maybe a lot of people would overlook, that things are different in different regions, what they have access to, the knowledge they have, the capabilities they have. So yeah, I think that's a really interesting point, and I'm glad you included that. Okay, we still have some time, and we still have lots of questions coming in. This is one that we haven't really touched on today. This is from Tony, and Tony says, can you comment on carcinoid heart disease and what that might tell you about progression of the overall disease?
Carcinoid, okay, so Tony, so that is actually a very, very valid question. Well, let me put some perspective on this. Mid-gut neuroendocrine tumor, let's just say mid-gut neuroendocrine tumor is the most common cause to generate carcinoid syndrome. Carcinoid syndrome essentially affects 20 to 25% of patients that has metastatic mid-gut neuroendocrine tumor. Heart carcinoid or heart carcinoid disease affect about 20 to 30% of the patient that has carcinoid syndrome. So it's 20-30% of 20-30% of mid-gut neuroendocrine tumor. So heart carcinoid heart does not affect everybody, but when it is, it's actually very hard to manage. It is a poor prognosticator on how patient will do, because disease in the liver or disease in the bone or elsewhere can be managed. But carcinoid heart, you need a valve replacement once you get there. And once you get there, you have valve replacement. Once you have a valve, then you have to try to control the disease so you don't cause further fibrosis of the valve that has been grafted on, or the new valve. So to me, it is a very hard condition to take care of. And it's also, to me, portend a poor prognosis. You need a very good multidisciplinary team that include a heart surgeon and a cardiologist to manage this. I have taken care of, through my 20 years, of several patients that live a long time with carcinoid heart, but it's not easy. So it's not something that you can go to any community place and say, oh, can you take care of me? You need specialists to be involved. But prognostically, I think it is a poor prognostic condition when it comes to neuroendocrine tumor or carcinoid tumor, because it's something that's not easily controlled.
Got it. I'm going to have to probably send you a screenshot or a document with all these great, now that we're nearing the end, a lot of really sweet, sincere comments coming through. Other people have echoed the best doctor yet, just want to say. But really, like, sincerely, people are very, very appreciative. I have a question. What would help you do your job better? What's missing in your toolkit for this disease currently that you, if you could make it be available, you would?
I think my best thing that I would say, this is a rare disease, and I love the community support. I love the patient support. And I love the scientific and medical support on finding new drugs, finding a new cure. But I think as an organization, whether as carcinoid foundations, whether that's NENNET, ENET, if we can get together and move the way forward to get people access to care better. I mean, we keep having to fight insurance to get a PET gallium scan. That drives me cuckoo. And we have to fight for PRRT for patients that is already FDA approved. To get new drugs, we have to fight all of this. We have to have a stronger voice. We are a rare malignancy, but we need a stronger voice. And as together as a group, that's what we need. We need to fight that front with regulatory, with insurance, with payers. That is what we need. That is very important.
And so for those people who aren't aware, like, is it just educating them on the things that we know about this disease, or is it just, what do they need to hear to make those changes?
So I think, the patient has to voice up. How do we form a group that represent us, a voice in the, let's say, when you're negotiating with Blue Shield, Blue Cross, when you're negotiating with this or that? How did breast cancer get advanced so far? It needs that political movement. It needs a little bit of political savviness. But breast is actually affecting everybody, mother, sister, grandmother, wife, all of that. And even some husband that has breast cancer. It affects a lot of people. We don't have that volume, but we can come together and have a political input in this a little bit better, because it's daunting when patient has rare disease and do not have access to things that could make a life different for them. I mean, it's a huge tragedy to me. I think that's what I like to see.
Yeah, I hear you. I feel you. What are some things that a patient can do to help, drive the success of this diagnosis, of this journey a little bit better, further? What advice would you give to a patient of how, they can't control everything, but there are some things that they can control and maybe help steer the ship a little bit better? What would you tell them that they should try to do?
I think this community of neuroendocrine tumor and carcinoid, Tumor is a fantastic community.
Agreed.
They love to teach other people. I even have a patient who said, but I want my local doctor to know this, so I want you to teach them so that other patient can be taken care of. So I think that the knowledge that they have, some of them actually have knowledge just as much as some community oncologists actually. And I find that fascinating because they know their disease so well. But I find that also is very important that they pass this information to everybody. They actually comes to me with, this new drug is now approved. I'm like, okay, I know, but you need to tell your other doctors. So I think educating, being active, if you have a chance to be active in any political movement or in any kind of civic, if you're in the government, this is the voice that you can actually say, hey, you guys, we need to spend more time talking about rare disease, not just the disease that already have tons of treatment, has 98% cure rate or whatever it is, like breast cancer. So I think we need to come together, both patient, foundations, organization, clinician, to do that. And I think that's what I would encourage. Get involved however you can.
Well, folks, you heard the good doctor. Dr. Phan, man, I'm really impressed with you. And, and you're not, it's, unique or alone in this purpose behind it, but it is so rich with you and so clear. Everybody that watches the show knows that I get emotional. So I don't want to get emotional now, but, I felt I resonated with you in the beginning, with your purpose, and it so clearly lights the way for you in this journey. And I just love the way that you are serving this community. I think that your parents would be incredibly proud of you. And I just want to thank you for spending this time with us. And I do want to send you some of these comments because the people are very, very clearly grateful and thankful for you spending this time today too. So thank you for spending this time with us.
Thank you for having me.
Absolutely. And thank you all at home. As always, clearly we wouldn't have a show without you. So thank you for joining us. And we hope, as always, that this program helped you. And if you have other questions or need more information, reach out to CCF, either at carcinoid.org, their website, or here on their Facebook page. You can send them a private message if you have any further questions or need more direction in your journey. Thanks again to our presenting sponsor, Tercera Therapeutics. Without their support, this program wouldn't be possible. And again, my name is Rain Bennett. Thanks for watching. Stay healthy, stay safe, and join us next time on Luncheon with the Experts. Bye-bye, everybody.